So it's my pleasure to share our experience in UZ Leuven here in Belgium when prescribing abemaciclib. Adherence is typically defined as a degree to which a patient follows a prescribed treatment or treatment schedule over a given time period. Adherence to and studying adherence to oral anti-cancer drugs is an emerging challenge in cancer care. Let's start with two statements. The first is quite logical. Medication adherence is considered the single most important modifiable factor with the potential to compromise treatment outcomes. This is logical. Regarding adherence on endocrine treatment, this statement from George Sledge group on the use of non-steroidal aromatase inhibitors, adherence is not only side effects, but also takes care of the baseline, the patient-reported health-related quality of life components such as poor social and physical well-being, but also potential presence of depression, all significant risk factors for adherence to endocrine treatments. Regarding CDK4/6 inhibitors, we don't have prospective studies on risk factors of adherence, neither we have on the association between adherence and efficacy. So what can we do to improve or to study improvement of CDK4/6 adherence? Can we define a population with a risk for low adherence? I think we should not do these studies because the studies have been done. Myself and colleagues, we did a study years ago on non-steroidal AIs, giving patients educational leaflets, but adherence was not better. In this randomized controlled trials, leaflets or no leaflets. Recently, ASCO 2021, Shah et al. Did efforts to improve adherence by giving welcome antidiarrheal kits. Unfortunately, or fortunately, they didn't see an improvement in adherence because the control group did very well in adherence, meaning that physicians and patients were well informed on this adherence. What I believe we have to do is medication experience. You have to share with your patients and with your physicians, explaining how to proceed, and also to your nurses, because in UZ Leuven, we have a strategy to involve patient, nurse, physician dialogue. So how do we go? We first explain potential side effects. We tell the patients that quality of life is maintained or even better. So pain is getting better. You have to stress the potential side effects that might involve adherence. You can see from this quality of life slide published from Monarch 2 that diarrhea is a potential problem. So all the rest is at least stable regarding quality of life issues. Important to share with your patients. Regarding experience with the treatment, what is the composition of the drug? How to start treatment, how to proceed. So we explain the patients based on this leaflet, tablets of 150 milligram. Patient takes the tablets with 12 hours interval, morning, evening, with or without food, not with grapefruit, avoid St. John's wort. So you explain the patients the potential side effects just by explaining this through a leaflet. The physician will tell you the exact dose, but we always start with a 150 milligram twice daily dose. Everybody is different. The best dose is the one you will tolerate. So then we go next to this other leaflet where we tell the patient other points of attention with abemaciclib, and then we focus on diarrhea. We focus on the regular blood tests, the importance on following the liver function. So all the rest, I think, is on a leaflet with consistent, clear and objective drug information, can be taken home, educational material, and a reminder that the patient knows what you have been telling her in the hospital. This focus on diarrhea is based on an algorithm published by Hope Rigaud and colleagues in The Oncologist quite recently. So you have to adjust, you have to interrupt the doses based on the diarrhea, on the severeness of the diarrhea. Two words are important: a prescription for antidiarrheal drugs, and enough non-alcoholic fluids when there is diarrhea. Instruct the patient when she needs to contact her physician. Instruct the patient early enough that she stops treatment, that she gets an adapted dose if required. Other interventions that might help your patient population giving CDK4/6 or abemaciclib is that the patient should be aware that discontinuation in the clinical trials was rare, less than 5%, and make the patient feel well that if the dose is needed to be modified, that this is not going to affect efficacy. So this will also improve patient adherence. Last, please also instruct your physicians and personnel involved in patient information. So make sure that reimbursement criteria are respected. Physician is aware of the mode of the actions, cycle duration, dosing, discuss adverse events, discuss serious adverse events, discuss alarm symptoms, when to go back to the physician and ask for dose modifications. So the physician needs to know what to tell the patient. In conclusion, CDK4/6 inhibitors have clearly improved quality of life for patients with ER-positive advanced breast cancer, not only delaying the start of cytotoxic chemotherapy, but also extending a productive life. Efficacy depends on sustained target inhibition with any of the three CDK4/6 inhibitors. Therefore, extensive guidance and proactive management are the keys to improve adherence. This, together with a close 7-to-7 on-treatment feedback by phone or online dialogue, in our experience, is needed in all, but especially also in older patients that you have to give these drugs. They have already a higher incidence of pre-existing complaints. I hope this will help you. Thank you for your attention.